This is Jerry Hesch from Hesch Institute in Aurora, Colorado. And my client Dory is an internal medicine physician. And she's coming to see me for diagnosis of sacroiliac joint dysfunction. And I'll have her sit in a little while and describe how she feels in sitting. When I load her left hemipelvis, I'm pushing up on the sit bone. I can load it and her whole body moves. And I push it until there's a stop. That's called taking up the slack. And from there I can add additional force and I see her whole body move. I see her head bob up and down. So I'm able to get movement through her sacroiliac joint and through the rest of her spine. On this side, on the right side, I'm doubling my force and I'm not getting any kind of movement. And you feel a little discomfort when I push up on this right side?
A little bit.
Okay, and where is that discomfort?
It's just in the ischial tuberosity in the sits bone.
Very good. So it's down in this area. And otherwise, your discomfort is primarily where?
Primarily when I'm sitting. I don't have a lot of discomfort when I'm up and standing, but when I'm sitting, it just feels like my pelvis is uneven and that I have my sits bone on the right side is out more, or there's more pressure on it. It just feels, and it kind of seems to move around too. It's not the same every day.
So do you ever get pain up in this area?
Sometimes, but
okay.
Yeah, it depends on if I've been sitting too long, or it depends on the chair. So
yeah. So you sat a little while ago on this chair, and you had those same symptoms in sitting on this chair?
Yes.
Good. Okay. So we won't have you sit to demonstrate it, but we'll have you sit after I treat you. The other finding with a downslip ilium is that movement in all other directions is normal. So I can take up the slack and spring the pelvis forward into rotation, and that moves. I can spring it laterally. I can load and spring it inferiorly. I see your heel move up and down, so the force goes through the sacroiliac into the hip joint, down through the lower extremity, all the way to the heel. And when you were on your back, and I did spring testing, there was good mobility there. So I'm going to treat you for the downslip pattern, and then I'm going to teach you how to maintain the movement that we gain. So it's fairly simple for you to keep that from recurring, or if it should recur, it should be simple for you to retreat. Usually when we move it back up, it tends to stay there unless you have some large passive force, such as a fall, or you twist and lift something heavy or something like that. So it should not come back, but know that you'll be able to self-manage it.
Okay.
And lie on your back. And scoot down so that your feet are off the edge. So what I want to do is create a vertical force through the pelvis to get the ilium. And that's your daughter, Emery. What, sweetie? I'm filming your mom.
But can I see?
I'll show you in a little while. Look. See the camera?
Yeah.
See the camera?
So why is it looking at?
Well, now I put it down and now I'm looking at your mom's feet. Okay? So that's Emery. Her nickname is Kiki. And how old is Kiki? You're 4? Wow.
And on my 5th birthday, I'm going to be 5.
Is that right?
Yes.
Excellent. Excellent. So what I'm going to do is create a force through her right leg at an angle in which I can perceive superior mobility. Now if I lean in with my thigh, I do not get vertical mobility. If I bring the leg out to the side about 10 degrees, I do not get vertical mobility. I'm now going to bring the leg into adduction, so I'm bringing it over. I'm sorry, wrong leg.
Yeah.
Wrong leg.
Yeah.
They should nickname me Wrong Leg Jerry. So here's vertical force on the right leg, all right? And we don't get much movement. I'm doing the same thing, abducted, not much movement. The typical direction is to have the leg adducted. So I'm bringing it across the midline, towards the midline of the body. About between 10 and 15 degrees of adduction. And this is the typical position for most people. Sometimes you'll need to do it with the leg straight or outward, but more than 80% of the time, this is the correct angle to correct a downslip. So I'm testing vertical force and I see her whole body move. So I'm just leaning into that leg and I see your head move up and down. Let me change the camera angle. Okay, so again we're adducted about 10 or 15 degrees and I can see your whole body move when I do that. So this is the angle of treatment. I'm simply going to lean into that leg, pushing up through the leg into the sacroiliac joint. And I'm going to maintain that force for 5 minutes. So I'm going to stop filming now. I want to show one last thing. Let's have you on your stomach again. The lowest sacroiliac ligament is called the sacrotuberous. So it comes from the bottom of the sacrum to the ischial tuberosity, therefore it's called sacrotuberous ligament. So I'm going to test the tone in that ligament. So here's sit bone, I find it with my thumb. Here's the bottom of the sacrum called the inferior lateral angle. So that ligament connects right there. So I just dig in a little bit and then I walk across and I can feel it. It's fairly dense. I can indent it slightly. It's a strong ligament. Okay? And when I come and find the ligament on the right, it feels like bone. I'm trying to indent it, does not indent. And this further adds to the theory that the hemipelvis has slipped downward on the sacrum because that would tense that ligament. And so after we treat, we're going to look for superior mobility being restored, and we're going to look for that ligament having an ability to indent slightly, and we'll also test how you feel when you sit. So I'll stop filming now and we'll refilm after I treat you.